I'd like to introduce our speakers for today's session, Isolation and Quarantine. We have two frontline medical professionals with us today to look at the timeline of quarantine here in the U.S., as well as self-monitoring considerations. And also, they will be speaking about containment of COVID-19 in an emergency room setting. Our first presenter is Monica Staples, and Monica is the International Nurse Program Director at the MGH Center for Global Health. Prior to joining the Center for Global Health, Monica served in the Center for Disaster Medicine, overseeing training for the Biothreat Response Team. She has over a decade of experience in emergency management, disaster, and hazmat response, and extensive clinical training in wilderness medicine and humanitarian response. Monica has worked in a variety of clinical settings, including emergency medicine, global health, flight medicine, general medicine, and clinical and classroom instruction. Monica received her BA from Trinity University, her AD in nursing from La Brea College, and her MSN with a concentration in acute care nursing from Northeastern University. She is currently pursuing a Doctor of Nursing practice, and her research focuses on the recruitment and retention of nurses providing humanitarian care. Lila Ullman is a registered nurse in Los Angeles, California. She started her nursing career at LIJ Medical Center in Queens, New York as a medical telemetry nurse. After moving west, she continued with medical telemetry nursing with a focus on neurology, and then expanded into critical care. She is now an emergency room trauma certified registered nurse at a level 1 trauma center in the Los Angeles area. Lila is particularly interested in infectious disease and humanitarian work. In her free time, she drives to Tijuana, Mexico, and provides medical care to refugees seeking asylum into the United States. She recently returned from a deployment in the Marshall Islands for a dengue fever outbreak and looks forward to additional deployments in the future. Lila received her Bachelor's of Science in Nursing from Binghamton University. She plans to obtain a tropical medicine certification in nursing and a master's in public health. So we're really excited about our highly experienced presenters today. Now, before we get started, I'd just like to tell you a little bit about International Medical Corps. We are a global humanitarian organization dedicated to saving lives and relieving suffering. Established in 1984 by volunteer doctors and nurses, we're a nonprofit with no political or religious affiliation and now have more than 7,000 staff members around the world. More than 90% of our staff members are local to the countries in which they work. Our mission is to improve the quality of life through health interventions and related activities that strengthen underserved communities worldwide. With the flexibility to respond rapidly to emergencies, we offer medical services and training to people at the highest risk, always working to strengthen local healthcare systems and promote self-reliance. In alignment with our mission, International Medical Corps is responding to the COVID-19 pandemic around the world, deploying medical supplies, training health workers, setting up triage, and screening sites and more. Together, we're ensuring that people receive the medical care they need while keeping health workers safe. In the U.S., International Medical Corps is increasing patient capacity at hospitals. We're delivering training and information series for health workers, and we are ready to deploy emergency medical teams. I'd now like to turn it over to Monica Staples for her update on isolation and quarantine.
Good morning, and thank you for hosting me. Before discussing the role of quarantine as a component of community response and containment for COVID, it is necessary to distinguish from a public health perspective between the related practices of isolation and quarantine. Both are usually imposed by health officials on a voluntary basis. However, federal, state, and local officials have the authority to impose mandatory quarantine and isolation when necessary to protect the public's health. Who exactly is in charge with quarantine? The federal government. The federal government will act to prevent the entry of communicable diseases into the United States. Quarantine and isolation may be used at U.S. ports of entry. and this is authorized to take measures to prevent the spread of communicable diseases between the states. At the state, local, and tribal levels, they are allowed to enforce isolation and quarantine within their borders. And it is possible for federal, state, local, and tribal health authorities to have and use all at the same time separate but coexisting legal quarantine power in certain events. But in the event of a conflict, federal law will be supreme. So this slide here just shows sort of a brief timeline, the history of quarantine in the United States. So this actually is not unprecedented. As you can see, back in 1799, due to a yellow fever outbreak, they did have to build the first quarantine station. And then we did see a reduction as vaccinations improved and they downsized. But then again, with the resurgence of SARS, other terrorist and bioterrorism threats, they did increase quarantine stations up to 20 back in 2007. These are some of the quarantinable diseases by executive order that you can see here. And what we do see is I've highlighted new types of flu that would cause a pandemic. So as we're now dealing with COVID-19. So again, this is a brief timeline, and I won't walk you through, but the importance of these dates is just to show you how quickly things really escalated. So back in December of 2019, the World Health Organization was first notified of this respiratory illness cluster in China, and then was identified as this novel coronavirus. As you can see how rapidly it really moved through up until February and really spread throughout the world. And then in March, the World Health Organization declares this a pandemic. And then, as I'm sure we can all relate to what's going on in our own individual states. And then here, March 24th, into India, a country of 1.3 billion, we've announced a 21-day lockdown. April 9th, actually we updated this slide late yesterday, but even as of this morning, we are up over 1.5 million cases and over 90,000 deaths. But recovery has increased. We have actually over 342,000 persons have recovered. Thankfully, with the introduction of antibiotics and vaccinations, we really haven't seen large-scale quarantines since the mid-20th century. But as we've started to see newly emergent diseases like SARS and Ebola and now COVID, we've seen a resurrection of this custom. So what are some of the practices that they've instilled? So one is, self-monitoring. So we're talking about social distancing, maintaining this distance of 6 feet from others, staying out of crowded places, knowing what symptoms to be alert for. We've seen the symptom list has actually been a dynamic list that has changed over the course of several weeks as, people have initially presented asymptomatic, and then when they are presenting symptomatic, the symptoms are very different. And I'll talk a little bit about some of the symptoms I saw in the setting that I was working in. So we do want to follow the CDC guidance for symptom management. So self-quarantine is actually, maintaining yourself at home in isolation under quarantine until 14 days after arrival. So, we're seeing this a lot. I'm on in the Northeast, so, we have warnings along the highway that if you're coming from another state, if you're traveling, that you self-isolate for 14 days prior to going out in the new environment that you are. Self-monitoring, this requires taking your temperature twice a day, and then monitoring for fever, cough, shortness of breath, and really avoiding contact with people at higher risk for severe illness. So this is the elderly, the immunocompromised. There have been a number of, changes that have been made in stores as far as, dedicated shopping hours for those high-risk groups. We're really seeing the public putting in some changes to protect our community. And again, following CDC guidance. So I want to talk a little bit about my experience with monitored quarantine. So I am a nurse specialist under the National Disaster Medical System on a disaster medical assistance team, a DMAT team. And we had a deployment recently where we were caring for some cruise ship passengers that were required to be quarantined for 14 days prior to returning to their states. So they were housed in a federal location, and our guests were placed in these units, and then for 14 days it was on a state-by-state basis if they were allowed to be returned to their state. And that was a conversation with the governor based on their testing and their symptoms. So our team was responsible for maintaining really everything at this site. So if you can see from the pictures, we had our tent outside, and then we had fencing completely around the building. And we had everything really went by unilateral flow. So you went into the building one way and then came out another way. And this was to avoid cross-contamination. We had multiple strategies in place. We really clustered care. So these were generally well people that had been on a cruise, so at baseline, in pretty good health. However, they were an older population, and they had really gone away with about, 14 days of their personal medication, maybe a couple of extra doses, give or take. But now, they hadn't planned for this additional 14 days. So, and they'd been at sea, I believe, a couple of extra days. So they really were out of medication. So that was another part of our clinical oversight. So we were responsible for twice daily temperature monitoring, provided all meals. We would hand deliver to their rooms, and this required our team going in, and we would go in full PPE. We would do all food was, individually wrapped, handed into the folks, and we would, maintain a certain distance to provide them with their food, and then twice check their temperatures. We did a lot of pharmacy refills for these people. And, really just getting to know them and making sure that we weren't missing any of the atypical symptoms, which we did have several people test positive, and I can tell you anecdotally, they were afebrile, so no fever, did not have a cough, but something just wasn't right. So we are all clinicians on this team, so, we were able to assess them and then make the decision to move them to a higher level of care for testing. But we would cluster care, so we would do the temperature checks in coordination with the meal delivery so that we were not putting, our people at higher risk for exposure and maintaining our guests, in isolation and in safety. So this was an interesting deployment. It was a successful deployment. And I wanted to kind of show you some of the pictures. I think that was just the right-hand corner was one of our team members in our full PPE. And then if you can see sort of the top picture is, the distancing that we would keep from the fence. So a lot of these folks would come out and speak with them and just help with their requests. So what happens after quarantine? So if you are one of the many people who are asked to quarantine for 14 days, you might actually ask what's the rationale for 14 days. And it really just has to do with how a virus works and invades cells and replicates. It infects the host and then takes some time for the virus to make copies of itself. And then the host will then shed the virus by coughing or sneezing. And then this is the virus's incubation period in others as it spreads. And then it's usually, for the host, it's the time between when we're first infected and when we start shedding the virus, which may be a little before we start experiencing symptoms. And again, the incubation period varies from virus to virus. So I know for the virus that causes COVID-19, researchers have found that the typical incubation period is about 5 days, and about 97% of the people who get infected and develop symptoms will do so within 11 to 12 days, and 99% will within 14 days. So in the United States, the Center for Disease Control and Prevention sets the quarantine period, and elsewhere, the World Health Organization. So the goal of the isolation and the quarantine is to break the chain of infection. And I think you've probably all seen, this idea of flattening the curve. And really, if we can break this chain of infection, we can hopefully keep our community healthy.
Great. Thank you, Monica, for that was a really interesting presentation on isolation and quarantine. And now Lila will take this discussion further. Please go ahead.
Hi everyone, my name is Lila Ullman. Today I'll be talking about isolation and quarantine, and I'll specifically be focusing more on the isolation aspect, and I'll be talking about it from my firsthand experience with containment of COVID-19 in an emergency room setting. So first, I'll be talking about just kind of CDC's guidelines in regards to hospital isolation. They have 3 key points, and the first point is limit how germs can enter the facility. So ways we do that is by canceling elective procedures, using telemedicine when possible, limiting the number of visitors coming in and out of the emergency room, screening patients for respiratory symptoms. The next thing I'll talk about is isolating symptomatic patients as soon as possible. So having well-ventilated triage areas, placing patients with suspected or confirmed COVID in private rooms, and if possible, with restrooms, prioritizing AIIRs or airborne infection isolation rooms for patients undergoing aerosol generating procedures. And finally, I'll talk about protecting our healthcare personnel. So how do we do that? Well, we emphasize hand hygiene, we install barriers to limit contact with patients at triage, we group our COVID patients together. We limit the number of people taking care of these patients, having appropriate PPE, prioritizing respirators, and airborne infection rooms for aerosol generating procedures. So I know that's a bunch of words, so I'm going to break down each point and kind of talk to you about how we do it at the facility that I work at. So first, I'll talk about how we limit germs entering the facility. So as of about maybe 2 weeks ago, we have canceled all elective procedures, and that has actually decreased the traffic coming in and out of our ER because we're seeing less post-operative problems coming through to us. We've limited our number of visitors. The only people who can have visitors are laboring women, people who lack decision-making capacity, people who are on comfort care, pediatric patients, and patient deaths. And I know specifically with COVID-19 deaths in my emergency room, if it is a COVID-19 related death, then there is only 1 visitor allowed, and they are allowed a 10-minute viewing outside the glass door of that patient. Next thing, I'll talk about our temperature checkpoints. We've actually started doing temperature checkpoints for employees, for visitors, and obviously patients. Anybody with greater than 100 degree Fahrenheit temperature is asked to leave the premises. And finally, masks. We mask everyone who comes in and out of the hospital, whether it be a visitor, a patient, or an employee. Everyone gets a surgical mask. Isolating symptomatic patients. So, like I said, we mask all of our patients with surgical masks. We have, as far as our triage area, the way our triage area kind of works is we have a first-tier triage and a second-tier triage. Our first-tier triage is where you tell us your chief complaint and why you're here. If you are having COVID-like symptoms, then we ask to continue the triage outside of our waiting room, and we do the intake and the vital signs and all of that outside the ER. And if the patient is considered what we call an ESI, or Emergency Severity Index of 4, which is people who are alert, they're walking, they're visibly not short of breath, their vital signs are doing okay, meaning their oxygen is okay, it's greater than 95%, then we direct them to our tents, which is where our more stable patients are. But if they have an ESI of 1, 2, or 3, then we direct them to our COVID zone in our emergency room. These people are usually more short of breath, they're having high fevers and things like that. As you can see on this slide, I've put out a little graph of what an ESI means. It just basically is a way of how we triage patients in the ER from very sick to not sick. The next thing I'll talk about are negative pressure rooms. So we do have 2 negative pressure rooms in our emergency department, only one of them being in our COVID zone. So how do we combat that? Well, we actually have HEPA filters, which are high efficiency particulate air filters, which kind of filter the air of any contaminants, and we put those in many of our COVID rooms. Restrooms, I know the CDC recommends that we use one restroom per patient, but that is just simply impossible, especially in emergency rooms. So we have been encouraging our patients to use commodes, use urinals when possible, use bedpans, use Pure Wicks or condom caps and things alike, just to minimize patients coming in and out of their rooms. But again, we can isolate them, limit exposure. Next thing I'll talk about is protecting healthcare personnel. Protecting healthcare personnel is essential in containing this virus and limiting exposure. I know a study showed in Spain approximately 14% of healthcare providers had been infected with this virus, and that could be for a number of reasons. But first off, PPE. PPE is so important. Having the right gowns, gloves, goggles, face shields, N95s and things alike are very, very important. And I won't go too much into PPE just because I know that there was a webinar on it already. Thing I'll talk about are hand washing stations. We have hand washing stations pretty much outside every patient room and throughout the department. Next thing I want to talk about is patient ratios. And I know the CDC doesn't exactly talk about that, but I do live in California, which is kind of the gold mine for nursing, and we do have patient ratios here. And in my department, we have a 1-to-4 patient ratio. And I think that's really important because it limits healthcare personnel and nurses going in and out of the room so many times and donning and doffing and making any mistakes with donning and doffing. As well as having adequate staffing is really important. Having people to help you while you're in that room and not going in and out, like I said before, having someone to give you equipment, which is where this runner is in my next point. I talk about this, a runner or a designated nurse who will go and grab medication for you, equipment, and things like pumps, because, you know, as nurses, we probably forget to bring in a Alaris pump all the time for hanging medication and things like that. We also have a designated charge nurse who kind of regulates the flow in and out of the COVID area and makes sure that we have all the equipment, all the intubation things that we need as well. Showers. Showers actually have started about maybe 2 or 3 days ago. Our facility is now providing us with showers so that we can shower after work and make sure we don't bring home this virus to our friends and our families. I think that's definitely eased some of the anxiety that some of our healthcare personnel have. And finally, I'll talk about RSI, or rapid sequence intubation, and resuscitation team protocols. I have a lot more to talk about that, so I will talk about that in the next slide. The goal for us, as much as RSI and resuscitation are very important for our patients and trying to save them, it's also really important for us as healthcare providers to remember to not rush into a room without having our PPE, without thinking before we go into these rooms, because ultimately what we want to do is we want to contain the virus. We want to isolate these patients and limit the exposure as much as possible. So CDC and WHO, what they recommend is, as far as aerosol generating procedures, healthcare providers should be wearing N95s, gowns, gloves, eye shields, face shields, or goggles, and these patients should be in negative pressure rooms when possible. They also recommend, as far as endotracheal intubation, to use video-guided laryngoscopy. So basically a gyroscope, kind of like a camera that you use to visualize a patient's airway. And that allows the provider to have more distant contact or distance from the patient's mouth, eyes, face when intubating. So now I'll talk a little bit about what we're doing to isolate, to contain this virus in my hospital. When we're doing these specific procedures, because remember, RSI and resuscitation are aerosolizing procedures, and we really don't want to be exposed to this. As far as PPE, we do the gowns, the gloves, the eye shields, etc., but we also wear a PAPR. So a PAPR is a power air purifying respirator. It filters out kind of like contaminants and prevents any of those aerosols from getting near your face. And it kind of looks like a helmet going on your head. Next thing I'll talk about is pre-oxygenation. So normally when we are intubating or resuscitating a patient, we would use an ambu bag or BVM a patient, which is a bag valve mask to pre-oxygenate patients. But at this time, that is considered an aerosolizing procedure. So instead, what we do to pre-oxygenate patients prior to intubation is we provide 6 liters nasal cannula and a non-rebreather mask at 15 liters. The next thing I want to talk about, which I kind of talked about already, is the number of people in the room. So we have limited the number of people in the room for RSI to the healthcare provider, the physician, a respiratory therapist, and a registered nurse. Everyone else has to wait outside, whether it be pharmacy, the runner, the charge nurse, and if anybody inside that room needs anything, then usually the runner will go and grab any equipment that they need. As far as the resuscitation, we do add one more person, which is a nursing assistant, who can assist with compression. I just want to also make a note that we do have intubation and PAPR carts outside of these rooms, just so that we don't have to run and get supplies throughout the emergency room, and we can intubate quickly and efficiently. Because again, the goal is to contain the system, isolate any of these aerosols in the air, isolate these patients, and limit the exposure of our healthcare workers. I will touch upon ambu bags again. So if a patient has a failed intubation, then our next choice for maintaining a patient's airway is placing a LMA, which is a laryngeal mask airway. We do that just in case we do fail our intubation. It's not a permanent situation for maintaining an airway, but LMAs cannot be hooked up to ventilators, so we have to, unfortunately, bag these patients temporarily with an ambu bag. But what we do include with our ambu bags is inline HEPA filters. And lastly, what I'll talk about are compressions. So when a patient is in cardiac arrest, we try to limit the number of people who are doing compressions, and we do have a device called a Lucas, and it's a machine that kind of does compressions for you, so then us healthcare providers don't have to touch the patient. Again, this is limiting exposure, isolating the patient. Okay, so now I'm going to kind of wrap up, and I'll talk about the positives and the challenges that we have faced as far as containment. So some of the positives, I think we have definitely limited the number of people entering the facility. I think we've done a great job at that. Medical screenings, like I mentioned earlier, the temperature checks. Those have been really helpful in who comes in and out of our hospital and our ER. Giving a surgical mask to everyone. Having designated COVID-19 and non-COVID-19 zones, I think those are essential in separating and isolating certain types of patients. Having clean versus dirty stations. So basically what that means is throughout our COVID and even non-COVID zones, for any equipment that we use, whether it be stethoscopes, eye shields, goggles, things like that, we do have our clean stations where we have cleaned off our equipment, and then our dirty stations, if we haven't had time in the moment to clean our equipment, we put it there just so that we can avoid cross-contamination between patients. And finally, having a team nursing model, and I think I've kind of touched upon this before, but in the next slide, I'll talk about that. So I think normally we have a primary nursing model, which is, one nurse is responsible for 4, 5, 6, how many patients you are, but we've kind of had to switch our mindset in the past couple of weeks and switch to a team nursing model. And what does that mean? That means we need multiple people helping one patient, because one, these patients are coming in very sick. They can't breathe, and multiple of them are coming in. And I think having a team nursing model, having a runner, a designated charge nurse, multiple people working on one patient has actually helped isolate this virus and contain the virus within one patient's room, and prevents a healthcare provider forgetting how to don and doff their PPE appropriately. So I think team nursing has been essential in the containment of COVID-19. Lastly, I'll talk about the challenges of containment. So who really is positive, right? So sometimes, unfortunately, what happens is we might triage a patient and their symptoms might not be consistent with COVID, and we put them in the non-COVID zone. And then later we find out, oh wait, they may actually be positive and they are having symptoms of COVID, and they go into the non-COVID zone, which is definitely presented a problem for us and we are definitely working on. But unfortunately, yeah, that does happen sometimes. As far as the tents go, not everybody is 6 feet apart in those tents. And then, this goes back to, again, who is really positive? Maybe someone is going into that tent and they might have COVID-like symptoms, but maybe they're not positive for COVID. So then maybe there's an unintentional exposure next to someone who is positive for COVID. So that is a challenge of one of our tents. Small triage area, I think that's just maybe related to my hospital personally. Our triage waiting room area is not very big, and although we do ask people who have COVID-like symptoms to wait outside, sometimes it gets very cold. Even though we live in LA, cold for us is 60 degrees, 65 degrees. And we do end up having some people come back into our waiting room and sitting next to each other and sitting next to people who are non-COVID patients coming in. Negative pressure rooms, unfortunately, we do not have enough HEPA filters for every single room that is not a designated negative pressure room. So if a patient comes into one of those rooms who needs to be intubated or needs an aerosolizing procedure, that is a challenge we face. So having appropriate PPE is really important, and making sure you donned your PPE appropriately is also very important. Restrooms, I mentioned this before, but we do not have singular restrooms. Some people do come out of the room and go and use the restrooms in our COVID zones. We try and limit those people from coming in other rooms, but again, difficult and a challenge we have faced. Staff and PPE. So I'm sure many people have maybe read on the news and seen that there's just isn't enough PPE and appropriate PPE. I would like to think that my hospital actually has been more fortunate, and we've had a good supply of PPE, but there have definitely been times where we've run out, or we've definitely reused PPE on multiple occasions, and we've had to buy our own PPE and get donations from other parties. And finally, the ER mentality, which I think I've also touched upon earlier. So the ER mentality is go into that room, everyone rushes into that room, and without their PPE, without thinking, hey, I might have exposed myself. I think that has definitely challenged a lot of our staff, because we're so used to going in and trying to save everyone's life and get a patient back, when right now we have to adjust our thinking and think we need to take care of ourselves if we want to take care of other people. And I think now we are definitely more vigilant about putting on our PPE and not everyone rushing into the room. But yeah, that has been a challenge of containment, because we do still have some people rushing into that room without anything on. Thank you, everyone. And now I will turn it back to Ryan.
Great. Thanks so much, Lila, for sharing your experience with isolation considerations in your ED. Personally, it was really interesting to hear how your facility has adapted to COVID-19 and on the team-based model for patient care in particular. So now we'd like to use this time for any questions that people have on the presentations for both Monica and for Lila. For Lila, can you speak a little bit more about the pediatric considerations? For example, if you have a child that's in the ED and parents who might not be symptomatic, but again, they're going to be, in the same household as the child, does that impact the visitor policy in the room, or how is that handled?
Yeah, that's a great question. I actually had a pediatric patient the other day who was actually rule out COVID patient, and as far as having a parent at the bedside, so we are allowing one parent in, and the rule is once they are admitted to the ward or the floor is once they're in, they can't get out, so they have to stay in that room with that patient the entire time. Yeah, so with pediatric patients, just one visitor and one visitor only.
Okay, great. Thank you. So our next question is, are there any particular suggestions or advice for low-resource environments where space and/or PPE might be limited? So this is directed to isolation. So I'm going to let Lila, you take the first crack at this, and then we can turn it over for Monica for any additions. Thanks.
Yeah, that's a very good question. And I've seen a lot of different things that my colleagues at work have been doing. So if you do have limited, let's say PPE, like let's say an N95, right? CDC and WHO actually say that you can reuse N95s until they are soiled. That's actually what we have been doing. So if you are able to get your hands on any N95, I know you're supposed to be fit tested for these N95s, but what we've been doing is, I'm not saying it's the best practice, but we have been putting our N95s in a paper bag to be reused. I've seen other people, what they've done with their N95s is they have taken like a Tupperware box and they've put the straps of the N95 around the Tupperware box just to avoid the front of the N95 from contaminating anything else, if that makes any sense. I know that's maybe not the best answer, and I don't exactly have the answer to that question, but it's a problem that a lot of people are facing. And you know, I'm from New York originally, and I know a lot of my friends in New York and my coworkers from my old jobs in New York have been facing that problem.
Great. I'll just turn it over to Monica to see if you have anything to add. On the original question was, are there any particular suggestions or advice for low-resource environments?
So I think Lila spoke well to that, and I noticed in the chat a link for resources at the CDC. I think there is a lot of work being done. I know I'm an emergency room nurse as well in a level 1 trauma center, and I sit on the reuse committee, and they've just implemented, they are going to sterilize, and we're going to reuse our N95s. There's a new system coming in, and they're going to be able to sterilize them. I know some of the tips for us has been in order to sort of preserve them, to make it through the sterilization process is, being cognizant of not wearing heavy makeup and skin creams for the mask itself. And, again, I think the CDC is trying to make some recommendations. So I think that, everyone it is a question that a lot of facilities have, and they're probably the best resource for that.
Great. Thank you, Monica. And I'd also like to refer people back to the PPE and monitoring webinar that we held on Monday, which can be found on the International Medical Corps website, which we did have one of our speakers focus on the decontamination and reuse of N95s in particular. So I'm just going to pause to see if we have any additional questions. Okay, and seeing none, I just wanted to conclude the Q&A portion of the webinar. And we'd all like to extend our deepest thanks to both of you, to Monica Staples and Lila Ullman, for taking time out of your schedules. I know you both work on the front lines, and to share your experience on isolation and quarantine with all of us. Some of us who, are not clinicians, or even if we are clinicians, might not be having those experiences. And so thank you so much for kind of for sharing all of your observations with us. We'd also like to extend a special thanks to our colleagues in Learning and Development for their support on the production of this webinar. And please join us for the next and final webinar of this series, which will be held on Monday, April 13th, on medical surge. And we will be joined by two powerhouses, Lindsay Martin. She's a nurse practitioner and Deputy Director of Field Operations at the Center for Global Health at Massachusetts General Hospital. And she will be joined by Amanda Ramsdell. And Amanda is an emergency department nurse at UConn, John Dempsey Hospital in Connecticut. And she's also a Sergeant First Class in the U.S. Army and the Emergency Preparedness Liaison Officer for FEMA Region 1. And they will share their experiences on both at the micro level, at the facility level on medical surge, and then also on the macro level, looking at how different states are implementing medical surge to provide additional capacity for patient care. So thank you so much to everyone again for joining us. We want to extend our best to you, your families, and your colleagues. Take care of yourselves, and we hope to see you on Monday. Thanks again.